Larry Mellick is a professor in emergency medicine and pediatrics at the Medical College of Georgia. But Larry, most people know you as a trumpet-playing procedure doctor with an unparalleled video series on YouTube that shows vignettes and, frankly, uncomfortable procedures with your ED patients. Until now, you have not been known as Dr. Testicles.
That's right, it's Dr. Testicle.
If you don't know how you miss a scrotum in a twist,
Call Dr. Testicle.
call Dr. Balls.
Well, there's always a first time for everything, right?
We're going to talk testicular torsion, and this is not something that you are famous for, but you actually have several articles on this.
Among those articles is one from Pediatric Emergency Care in 2012. Torsion of the testicle, is it time to stop tossing the dice? And many of you have probably seen this article as it was an LLSA required article in 2014. In that article, Larry goes through a number of dogmatic teachings that we've heard from our urologists, as well as our field as well.
Myth 1. History and exam can reliably rule out testicular torsion.
Most of the time, we're pretty lucky. We're lucky just simply because epididymitis, which is the most common misdiagnosis for torsion, is a lot more common. It's relatively 3 or 4 times. It just depends on the age group you're looking at. Much more common. And then, so as a consequence of that, people have gotten away with trying to depend on the history and physical examination. But what I found in this article, which was absolutely fascinating, but is something that I still see new residents in our program will have the belief that you basically can make the decision about whether it's a torsion or an epididymitis based on the history and examination. And you can to a point, because there is a classical presentation of testicular torsion, but you actually will get burned eventually. And what's kind of fascinating, one of the articles that I reviewed was by a urologist who had a large case series, and he was touting that the physical examination and the history was highly reliable. And what was ironic about it, 12.5% of the patients that had torsion were misdiagnosed. So, wait a minute. Where do you get off with saying that this is such a wonderful, tool for making the diagnosis of testicular torsion? Somewhere between 5 to 10% of the time, you're going to get fooled. And so it is tossing the dice. It is a gamble. And so I propose that everybody should just get an ultrasound, knowing that there are some problems with ultrasound, but that's where you have to go.
Now, when you say everyone should get an ultrasound, surely there's a trigger, because is it just testicular pain alone, a testicular ache, a little bit of testicular swelling? And I think that there is a trigger. If someone has testicular pain in the ED, if you have ultrasound, they're getting an ultrasound just because of this concern. Testicular torsion, I think, is something that you could potentially rule in by exam, from what I hear you saying, but don't necessarily rule it out by saying, looks like epididymitis.
Yes, exactly. So if you're confident that it's a torsion, we'll just call the urologist and head to the operating room. But if you're saying, well, I think this is epididymitis, you're going to be wrong sooner or later. You may be right, frequently, but you're going to be wrong sooner or later.
Dogmatic teaching number 1 is that the physical exam can reliably rule out testicular torsion. The article most commonly quoted is by Mushtaq and colleagues entitled Retrospective Review of Pediatric Patients with Acute Scrotum in 2003. These authors showed a sensitivity just in the 80s, which I don't think would make any of us confident. You're still going to look for the abnormal lie, the high-riding unilateral testicle, and the absence of the cremasteric reflex, because the presence of these is very specific and you can use them to make the diagnosis. You just can't rule it out based on the absence of these findings. That brings us to the next dogmatic teaching.
Myth 2. No testicles are salvageable after 6 hours.
Torsions that present after 6 hours are not salvageable and no longer need to be evaluated in a timely manner. Isn't that the ischemic cutoff?
That's what everybody teaches. That's what the textbook teaches. That's what you hear from urologists frequently. But truth is, there are case series after case series of patients who had testicular torsion and the testicles survived much longer than a mere 6 to 8 hours.
Well, how long are we talking as far as survival time? Is it 10 hours, 12 hours, a day, 2 days?
There are case reports of testicles that have survived for days. In my article, A Systematic Review of Testicle Survival Time After a Torsion Event, I start out with a case. It was a young man, 17 years old, that had torsion. He had torsion for over 70 hours. And when I called him, it wasn't my patient, but when I got wind of his case and I called the patient a week later, I said, "How are things going? How's your testicle?" And he said, "This feels normal. I don't have any pain. It's normal size and everything like that." There are clearly patients out there whose testicles can survive for days.
That's right. I'm not some sort of girly testicle.
Days to weeks of survival is definitely not the norm, but Larry notes that the classic teaching of the 6-hour cutoff is clearly incorrect.
What I found with those 1,283 patients was that there was a 97.2% survival at 0 to 6 hours, and then 7 to 12 hours, there was a 79.3%, and then 13 to 18 hours, there were 61.3%, and then 19 to 24 hours, it was 42.5%, 25 to 48 hours, 24.4%, and then greater than 48 hours, there was like 7.4%.
Even up to 48 hours, there's an almost 25% testicular survival rate. Bottom line is that once you find the torsion, regardless of how long the symptoms have been present for, the patient needs a urologist.
Myth 3. Color Doppler ultrasound can reliably rule in torsion.
This is something that comes up with testicles and ovaries. Color Doppler ultrasound is a consistently reliable tool for confirming the diagnosis of testicular torsion.
That's a potential problem because, and I think we're getting better and better with our ultrasound machines are getting technically so much better over the years. And so it's been a process, but there still is this issue is that you will still see blood flow on patients who have a clearly torsed testicle. And there's some reasons for this, most likely. And one of the biggest reasons is the thickness of the spermatic cord. The thicker your spermatic cord, the less of a torque that happens. And as a consequence of that, there will be more blood flow to those testicles. And then also the number of twists in the torsion, the number of times it has gone around, that also will have an impact on the actual survival.
Back in September 2016, Jess reviewed testicular torsion ultrasound on EMRAP HD. Since this is such a visual thing, go over to the site and check that video out. The bottom line is that in up to 25% of confirmed torsion cases, there's still flow present on ultrasound. This brings us to a critical question.
Well, should I just give up on ultrasound altogether? No, ultrasound is still an excellent tool. You know, you look at the grayscale, you look for whether it's still homogeneous or it's no longer homogeneous. You look for the blood flow or the absence of blood flow. It's still an excellent tool. But on the other hand, if you're still convinced that this may be a torsion based on your exam, then you have to do something about it. And that means calling your urologist colleague and pulling them in and admitting the child, doing serial ultrasounds, are just a few of the steps you probably would have to take.
Myth 4. You don't need to palpate.
You've written about the pain honeymoon in testicular torsion. And is that like the testicular equivalent of the lucid interval in an epidural hematoma?
I think that's a good analogy. It's fascinating that I would be reviewing these cases, or actually a number of my patients have come in and they're just sitting there smiling, joking, and they've got a dying testicle. And I would say, "Are you in pain?" "No, not really. I'm not hurting. I don't have any pain." I mean, yeah, if I bump it, I'm sleeping through the night. If I roll over and bump my testicle, it'll wake me up, but then I go right back to sleep. I would see this pattern where patients would have a classical presentation. They'd be given some morphine or Dilaudid and some nausea medicine because they were vomiting, and then their pain was gone. And if the physician missed the diagnosis, and let's say they just presented with abdominal pain, which happens in maybe up to 20% of the torsion patients.
Whoa, let's not gloss over that number so quickly. Up to 20% of patients with torsion will present with an isolated abdominal pain or flank pain. That's a scary number, and it reminds us that we have to perform a testicular examination in patients presenting with lower abdominal pain.
And if they miss the diagnosis, these kids will go home and sleep through the night, carry on fairly normal activities. When I would see this pattern, it was like really confusing to me. Like I said, how can that be? You've got a dying testicle. But a day or 2 or 3 days out, all of a sudden they would start getting pain. And what's happening then is that dead testicle is now causing inflammation of the scrotal sac. Part of the confusion here is that the innervation of the testicle is different than the scrotal sac. There's 3 or 4 nerves that come down and innervate the scrotal sac, but the nerves that innervate the testicles originate from T11 to L1.
Slight correction there. Larry states later on that it's actually T10 to L1 for the pain innervation.
And as the testicles descend from the area of the kidneys and then descend into the scrotum, that innervation comes with them. And that's why it's fairly easy to do a nerve block of a testicle. But that also, I think, explains why we have these pain honeymoons, is as the testicle twist and as the ischemic process is happening, that nerve gets ischemic too. There's basically a paresthesia because that nerve is compromised.
That paresthesia explains the pain honeymoon that occurs and can so often fool the clinician. With all the difficulty around making this diagnosis, Larry notes that we also do ourselves a disservice when we don't perform the palpation part of the exam.
Early on in a testicular torsion, the scrotum looks perfectly normal. And if it's a cold room, the air conditioning's going full blast, you may have the dartos muscles working overtime, and so the scrotum is tucked up there, the testicles are tucked up tight, and so they just look perfectly normal. But it's only until you actually palpate the testicle that you'll find the patient says, ouch, my testicle hurts. I know my pain is usually is right now in my abdomen, but now when you touch the testicle, it hurts. And then you'll find a transverse lie, you'll find swelling, you may find something consistent with a hydrocele. And so you'll make the diagnosis of torsion. But if you don't touch the testicle, then you potentially have a problem.
Myth 5. The open book method always works.
Despite all the difficulties surrounding the diagnosis, you make it anyway. You call your urologist and she's on the way in, but she asks you to perform the classic detorsion procedure while the OR is getting ready for the patient.
Remember that about a third of the time that the testicles torse in the opposite direction. Usually we talk about use the open book technique to detorse the testicles, but you may be making things worse about a third of the time. So be very careful. And then if you do attempt to do a manual detorsion, followed up with an ultrasound, and also recognize that you may have really only partially resolved the torsion. And there are a number of case series out there that talk about having taken patients to surgery that had a detorsion event before, and they found that close to 30% of them actually were still torsed.
This is huge because I think that you see that in the textbooks. Hey, you see the torsion? Just open the book, right? Twist it to the outside and then you will detorse. But it might be wrapped around a bunch of times. You might have actually done nothing. Maybe you can help it. It's okay to try it, but don't think that you have cured the patient until you've confirmed. And even the ultrasound is not perfect. So it seems like there's no winning here.
Yeah, it seems like it, but I would say don't give up hope, because I think most of the time our diagnostic tools work. Most of the time the systems work. But I tell my patients all the time, I stay humble in this business because diseases don't read textbooks. And this is a perfect example of that.
Summary.
Larry's review article is short and easy read, and one that we should all look at so we can start dispelling these dogmatic teachings.
Myth 1.
Your history and physical exam isn't enough to rule out the disease. Be humble and get the ultrasound. The classic history and physical won't always help you differentiate torsion from other more benign causes of testicular pain like epididymitis. Again, get the ultrasound.
Myth 2.
Time is testicle. But just because it's been more than 6 hours of symptoms, it doesn't mean the testicle isn't salvageable. Up to 1 in 4 patients with more than 24 hours of symptoms will still have salvageable tissue. Always get your consultant on board.
Myth 3.
Ultrasound isn't 100% accurate. A considerable number of patients can have flow on ultrasound, but still have torsion. If you're very concerned for torsion based on your exam, don't let the ultrasound push you away from that diagnosis.
Myth 4.
Remember that up to 20% of patients with torsion will have abdominal or flank pain alone. Examine the genital area in all of these patients, and that includes palpation, not just visual inspection.
Myth 5.
And finally, remember that not all torsion will be solved with the open the book technique. Start with that, but confirm that the patient actually has improvement of symptoms. If they don't, consider whether there's been multiple twists and you haven't fully relieved it, or the testicle is torsed in the opposite direction. If the pain improves, get another ultrasound to confirm resolution.
That's right, it's Dr. Testicle.
If you don't know how you miss a scrotum and a twist,
Call Dr. Testicle.
call Dr.
That's
Boston.
right, it's Dr. Testicle.
If you don't want to miss a scrotum and a twist, call Dr.